disease in small animals, particularly dogs and cats. So just a brief overview of this presentation. We'll go through just a little bit of background, diagnosis, common clinical signs, treatment in dogs, treatment in cats, non-pharmacologic treatment options, and new therapeutic options that have come out recently. So that brief background, Cushing disease is also known as hyperadrenocorticism. It affects roughly 2 in 1,000 dogs. It is very, very rare in cats. There's not even really numbers out there to quantify that. About 80 to 90% of these cases are pituitary dependent, meaning that there's a tumor on the pituitary gland, and about 15 to 20% of dogs have an adrenal dependent pituitary tumor. So moving on to the diagnosis, there are no 100% accurate lab tests to diagnose Cushing's disease. They are really mostly relevant in dogs. There is just not enough of the enzyme needed in cats to accurately diagnose, especially with the SAP, the serum alkaline phosphatase. So what else they're looking for is an increased ALT, hypercholesterolemia, steroid stimulation of lipolysis, hyperglycemia, and decreased BUN. So those common clinical signs, you can see a few pictures on the left. Those are more extreme cases. What they're looking for is polydipsia, polyuria, polyphagia, heat intolerance, lethargy, abdominal enlargement. That's the top picture on the left that you can see there. That's that pot belly effect. And in dogs, you see panting as well. Muscle weakness, recurrent UTIs, alopecia, so hair loss, are pretty common there. And then in cats, you see a lot of thin, really fragile skin, as well as comedones and bruising. Moving on to the treatment options. First, we'll go over a few treatment options in dogs. And one other thing to know, especially about dogs, there are some breeds that are more prone to Cushing's disease. Poodles, especially miniature poodles, as you could see in the first picture back there, they are pretty prone to it, as well as Dachshunds, Boxers, Boston Terriers, Yorkshire Terriers, and Staffordshire Terriers. So the first drug that we're going to talk about today is mitotane, and the way mitotane works is it selectively destroys glucocorticoid secreting cells of the adrenal cortex. Now this one does have an efficacy of about 80%. That is according to one of our drug references here at VetRx Direct. So the dosing schedule on this one does need to be very carefully monitored by a veterinarian because there are a lot of different ways that it can go. Now, according to Plum's Veterinary Handbook, Merck Vet Manual, as well as a couple of the hard copy resources on internal medicine for small animals, you're basically looking at an induction phase and a maintenance phase. And in this induction phase, you're looking at 25 to 50 milligrams per kilogram per day for 7 to 10 days. And that can be once a day or divided every 12 hours. So that would be that 12.5 to 25 milligrams per kilogram per dose if you are dividing that every 12 hours. And then the maintenance dose, you can see a very wide range there of 26 to 336 milligrams per kilogram per week. So that's another reason that it really does need to be monitored by a veterinarian, is because so much of it is dependent on the dog's response and clinical efficacy. So monitoring, a couple things we want to watch out for are anorexia, vomiting, and diarrhea. Those can be pretty common side effects, but they could also show that something else is very wrong if the dog is really showing that. So for this reason, they do recommend prednisone or prednisolone upon occurrence at the dose of 0.15 to 0.25 milligrams per kilogram per day. And like I said before, a couple of those adverse effects to watch out for are GI irritation, ataxia, weakness, and seizures. Now, that depression and ataxia can be avoided by dividing the doses into 2 equal parts, 8 to 12 hours apart. So that's really what you're looking for when you're looking at that 12.5 to 25 milligrams per kilogram per dose to every 12 hours. And then mild hypoglycemia, that can happen. And on rare occurrences, it could cause other problems. That's definitely something that you want to let your veterinarian know about. So with the diagnosis, that increased SAP, you will see that as a side effect of this medication as well. So that's not really a great lab parameter for us to look at. So there is extra label usage. So extra label is really another term for that off-label usage. So they can use it as palliative medical treatment of adrenal carcinomas or medical treatment of adrenal adenomas. So that dosing is going to be a little bit different, a little bit higher at 50 mg per kg by mouth daily divided doses for 10 to 14 days with a maintenance phase of 100 to 200 mg per kg per week in divided doses with that glucocorticoid supplementation, prednisone or prednisolone at 0.2 milligrams per kilograms per day. So there are a couple of mitotane drug-drug interactions that we do need to watch out for. These are arranged from most common here at the top and then to least common down at the bottom according to how often we see these. At the practice site that I am in right now, VetRx Direct, we do not handle controlled substances, so our list is a little different. This one is derived from Plum's veterinary medicine. So the first one is CNS depressants. Those can have additive depressant effects. Then there is fentanyl, increased metabolism. Insulin is one that we see a lot, and insulin may be decreased when mitotane is initiated. So generally when a patient is started on mitotane and they are already on insulin, they increase that insulin dose preemptively, but that really is according to the veterinarian. So midazolam, there is an increased metabolism. Phenobarbital, that's another one that we see a lot with animals. That one can induce enzymes and reduce the efficacy of mitotane. Conversely, mitotane can induce hepatic microsomal enzymes and increase the metabolism of phenobarbital. Siligeline, that one has an increased metabolism and a decreased efficacy. Spironolactone blocks the action of mitotane, so really you want to switch diuretics when you start mitotane if they're already on spironolactone. Then warfarin, it seems like there's always an interaction with that. There is an increased warfarin metabolism. So a couple of big counseling points for mitotane when you are dispensing it is going to be to counsel the patient to handle with gloves to prevent absorption because humans can absorb that medication and we don't want those unwanted side effects. So, and also to give it with food, especially foods that are high in fat. The positive effects are usually seen in 5 to 14 days. Now, a lot of these lab values we won't really see, but you will notice your pet eating, drinking, and urinating less. Because it is a Category X drug, pregnant women should not handle this drug, and with any stomach upset, that's when you want to start that emergency prednisone, contact the veterinarian, and let them know right away. So trilostane is the next one that we're going to talk about today. So the efficacy of this one is a little greater than 80% as well. So this one is in the same class as mitotane, but it inhibits the 3-beta hydroxysteroid dehydrogenase, which is going to suppress progesterone production. So the dosing schedule in this one should be monitored as well, and the dosing is different. There is a table down below for how they kind of dose it, but that starting is usually around 2.2 to 6.7 milligrams per kilogram per day, or 1 to 3 pounds per day, or 1 to 3 milligrams per pound per day for 7 to 10 days, and they can do that once daily or divided Q12 hours. And on day 14, that's when they would use that table down below. So the monitoring for this one is in Addisonian crisis. There can be sudden weakness, severe vomiting or diarrhea, as well as possible collapse. Any of these signs are mean that you should immediately contact your veterinarian to see what your next steps are going to be. So the adverse effects on this one are lethargy, electrolyte abnormalities are a little more common than in mitotane, vomiting, diarrhea, and inappetence. There can be some long-term effects according to Plums, including GI upset, weakness, and long-term lethargy. So there is extra label usage for this one as well that I included. So alopecia X, it can be common in Alaskan Malamutes and miniature poodles and Pomeranians. So the dosing is listed there in Alaskan Malamutes being 3 to 3.6 mg per kg twice a day for 4 to 6 months, and then for miniature poodles and Pomeranians, average dosing is about 10.85 mg per kg per day given once daily or divided twice daily for 4 to 8 weeks. There was one study showing efficacy in just 1 mg per kg BID. So really it is up to your veterinarian in the extra label usage. And as well as in mitotane, trilostane does have some drug-drug interactions. Just like the last slide with the DDIs, you're going to have the most common at the top to the least common at the bottom. ACE inhibitors are noted as an interaction with an increased risk for hyperkalemia. Like I said before, some of the adverse effects can be electrolyte abnormalities, and this would just really make it worse if you're adding that ACE inhibitor like lisinopril. Aminoglutathione can potentiate the effects of trilostane and lead to hypoadrenocorticism. Ketoconazole can also potentiate the effects of trilostane and lead to hypoadrenocorticism. Then mitotane, that one is contraindicated with trilostane. So if you have somebody that's going from mitotane to trilostane, you want to make sure that they've got at least 1 month between those two. So potassium-sparing diuretics, those can also lead to that hyperkalemia, like I said, with that electrolyte imbalance. We don't want to potentiate that. Then potassium supplements and high potassium foods, those can also lead to an increased risk for hyperkalemia. So a couple counseling points on that one. Just like in mitotane, you're going to want to counsel the client to handle with gloves to prevent absorption. This one, give in the morning with food. This one, there's not as much of an indication to give it with a high-fat meal. That's just a different thing about the drug itself, but in the morning, unless otherwise directed. It should be closely monitored, like in the table on the slide before. And this one, you can see the positive effects in 1 to 2 days, but you won't really notice it. It's really up to the veterinarian to make those determinations. And it is pregnancy category X. So pregnant women should not handle this drug, and the veterinarian should be contacted if your pet stops eating or drinking or acts sick. Now, those steroids, I am going to talk a little bit about those. Prednisone or prednisolone, they're really grouped in the same thing. You can see their structures are kind of similar up top here next to the name. So the dosing on those are about 1.15 to 0.25 mg per kg per day upon occurrence of side effects. That's really indicated in mitotane according to Plums, but they could use it in trilostane according to your veterinarian. The side effects with that can be greater appetite, thirst, mild vomiting, diarrhea, or behavioral changes. A lot of the same side effects that you see in humans as well. So, and upon those side effects, that's the GI upset and anorexia, just as a reminder for what you would give that glucocorticoid for. And then monitoring on that is because it can cause similar adverse effects to the clinical presentation of Cushing disease, you want to always contact your veterinarian when you're starting to use those glucocorticoids. And there can be continued GI upset, anorexia, or lethargy. So those are something that you want to really let vet know about. So important drug-drug interactions with that one. Mitotane is actually a drug-drug interaction. So mitotane could alter the metabolism of those steroids, and sometimes you need higher doses than usual to treat that mitotane-induced adrenal insufficiency. So that's something that you just want to talk to vet about. The dosing given on this last slide over here does account for that, but as always, ask vet. So the counseling points on that one are to just give as directed upon the onset of those GI symptoms or anorexia, and to give with food. As well as another important point, it is a little more rare, but in dogs with stomach or intestinal ulcers or perforation, there is an increased risk of bleeding. Another drug that we see in dogs who have Cushing's disease is ketoconazole. Ketoconazole is less effective than trilostane or mitotane with efficacy of less than 50%, and it works by inhibiting enzymes responsible for cortisol synthesis. Now this one is only indicated for dogs with adrenal tumors or dogs who are unable to tolerate mitotane at the necessary doses. So the dosing on this one is a little different. The initiation is 10 milligrams per kilogram by mouth every 12 hours with a maintenance dose up to 20 milligrams per kilogram every 12 hours in some dogs, but that really is dependent on your vet and the clinical signs of your dog. So a couple adverse effects to watch out for include anorexia, vomiting, diarrhea, lethargy, thrombocytopenia, and idiosyncratic hepatopathy. So another one that has been studied, this one is even less effective than ketoconazole, of less than 20%, is selegiline. Now, selegiline decreases pituitary ACTH secretion by increasing dopaminergic tone in the hypothalamic pituitary axis. And this goes on to decrease serum cortisol concentrations. This one is only for dogs with uncomplicated PDH. So the dosing on this one is 1 milligram per kilogram per day, with a maintenance dose increased up to 2 milligrams per kilogram per day after 2 months if the response is inadequate. You can see the brand name Anapril on the bottom right hand of the slide, and that's really what we see here. So the adverse effects of this one are pretty consistent with every other drug that we've seen for Cushing's disease, as anorexia, lethargy, vomiting, and diarrhea. So another non-drug therapy is radiation therapy. There is a really high response rate with this one, but it can be very expensive. Survival times range from about 11.7 to 24.8 months after treatment, and it is common in small tumors. So there are some newer studies in macroadenomas, but really it hasn't been studied to the point where we can say that that is a true recommendation for a macroadenoma. So, and also with radiation therapy, there is ancillary mitotane or trilostane required, and that is just to make sure that they really got all of that tumor and to stop any residual ACTH secretion. Surgical intervention is another option for dogs with Cushing disease. The efficacy runs about 80% for surgery. So this surgery is called a hypophysectomy. There is 80% remission and 11% recurrence of Cushing's disease after the surgery. So additionally, after the surgery, there is thyroid and glucocorticoid support necessary and a possibility of developing diabetes insipidus. And there is a little bit longer than radiation of a prognosis of 2 to 5 years. So just a summary table. This is in the handout as well. The big drugs that we see for dogs with Cushing's disease are mitotane, trilostane, and a glucocorticoid, prednisone or prednisolone. So moving on to cats. Like I said before, this is very rare in cats, so there aren't as many slides on this, and a few of them are the same drugs as well. So mitotane can be used extralabally, and the dosing schedule should be carefully monitored by a veterinarian as well. So usually they start about 50 milligrams per kilogram per day divided, but really it's not well studied. So trilostane can be used extralabally as well, and the dosing schedule, like mitotane, should be carefully monitored by a veterinarian, and all of these counseling points for mitotane and trilostane are going to be the same as if you were counseling a client who has a dog. So in trilostane, the doses range from 10 to 30 milligrams per cat. I thought this one was interesting because it's not per kilogram, it is dosed per cat. By mouth every 24 hours, up to 12 milligram per kilogram by mouth every 12 hours. So the average doses in a few studies were 4.3 milligrams per kilogram once daily, or 3.3 milligrams per kilogram every 12 hours. So these are initiated at 30 milligrams per cat and adjusted based on clinical response. So surgical intervention is really what we see when we have cats because they are not as responsive to drug therapy. So the different options are adrenalectomy, hypophysectomy, and bilateral adrenalectomy. So post-op from that bilateral adrenalectomy is going to be hypocorticism, so they will need therapy from an injectable DOCP or fludrocortisone for the rest of their life. And just another note is that adrenalectomy is the treatment of choice in cats. So just a summary of cats. There are two drugs that we really see, and we don't see them very often, are mitotane and trilostane. The dosing is a little bit different, but the counseling points are very similar. So a couple new therapies that have been studied in the last 5-10 years. One is retinoic acid, or we see it in the human world as ATRA. And this one has anti-proliferative effects on corticotroph tumor cells. In 2006, there was a study that compared retinoic acid to ketoconazole. And clinical signs and survival did improve with ketoconazole. You can see the table of the main results right there on the bottom. Then on the right-hand side, you can see that there was a greater survival with retinoic acid. This one really hasn't been studied since this studied, and it was in dogs only. So one of the reasons that could be, now this is just my personal speculation, is because this is a very expensive drug to work with, and we have one that works pretty well compared to the ketoconazole. We have mitotane and trilostane. So, but as therapies develop, this is one that we could look into. So pacitriotide is one that's been studied a few times. It's approved for humans with hypoadrenocorticism. So in one study, they looked at 9 dogs with macroadenomas, all received concurrent treatment with mitotane and trilostane with these as well. There were no adverse effects or neurologic abnormalities in comparison to the control group, and it was effective in reducing tumor symptoms, but all in all, there are further trials needed moving forward. So abiraterone, this one we really haven't seen, but they have looked at in vitro studies showing success in reducing ATCH production. This one was in 2018, so it is a little more current than the other studies. And they took cell cultures from the adrenal glands of 7 healthy dogs and showed no interference with cell viability. So there was a suppression of cortisol synthesis at 92.5%. So this one could be something coming down the pipeline. So here are my references. If you have any questions at all, please send me a message, leave a comment, and we will see you next time.